All right, well, welcome everyone. Welcome everyone to our clinical conversation sessions. Today I'm going to get us started and give a quick introduction before I turn it over to the person who is going to be introducing the other speakers as well. My name is Barry Sarvat, and I'm the statewide medical director for McPap. And as you know, we have our McPap clinical conversations every fourth Tuesday each summer, each month. I'm jumping the gun here. We're actually, just to remind people that we are taking a break. We do take a break during July and August. So the next session will be the fourth Tuesday of September. So we're really excited to talk about a new topic that we haven't discussed before today. And the topic for today is called paternal postpartum depression. And it's really about the importance of fathers in the development of children and helping to protect children from behavioral health, prevent behavioral health conditions for kids and resiliency. And so it's going to be a great session. We have really a lot of good speakers who've been devoting a lot of their time to this area. But before we get into it, just a quick housekeeping note. As we've told you before, we have CMEs particularly for physicians and nurse practitioners. And the CMEs are being administered through Mass General, and we really appreciate their help with that. In order to get the CME credit, you have to use your phone to text a code. And as you see on the screen, the code for today is T as in Tom, E-G as in golf, T-A-K as in kitchen. At the end of the session, you will need to complete an evaluation and receive your certificate. We are, as always, recording the sessions, and they're available on the McPap website under the Tools and Resources section under PowerPoint presentations. And we will be glad to take questions throughout the presentation. Just type them into the chat or the question box. We will monitor the chat, and if it's relevant to what we're talking about at the time, we'll try to cut in a little bit to ask the question for you. And if it's something that's a little bit different from what we're talking about, we'll save them for the end. And please, just as a reminder, fill out the survey at the end following the presentation. The presenters today, I'm just going to read, there's actually 5 people, actually 4 people that we're introducing. The first person introducing is Dr. Michael Yagman, who is the CEO of the Yagman Pediatrics practice and is an assistant clinical professor of pediatrics at Harvard Medical School. Mark Friedman, Dr. Mark Friedman is a retired pediatrician with 20+ years of experience who's practiced in Norwood, Massachusetts. We have Charles Daniels, who is a therapist and is the CEO of an organization called Fathers Uplift, which I'm sure we'll hear about. And then we have Daniel Rodriguez, who is the Director of Substance Use Disorder Services at the Duffy Health Center. So I'm gonna, without any further ado, hand over to Dr. Yagman to continue with introducing the session for us. So Dr. Yagman.
Well, thank you, Barry. Can you all hear me? Just want to check. Good. So one revision. I've moved on from Yagman Pediatrics. I'm now at the Cambridge Health Alliance part-time in Cambridge Pediatrics, and I actually have patients scheduled in a bit. So I'll do my bit of my introduction, but then I'll have to drop off and go back and see patients. So we want to talk today, and I'm very excited about the distinguished panel we have. But we want to talk about paternal postpartum depression. And one comment to begin with about nomenclature. I think we've begun to acknowledge that we're not just talking about depression, we're talking about anxiety, we're talking about PTSD. So the new term across the board for mothers and fathers is perinatal mood disorders. The first issue is to emphasize the important role of fathers and that their mental and physical health has been found to have a major impact on the health and development of their children, most importantly in terms of their perinatal mood. The reviews of the literature on depression in the perinatal period, the prevalence here is all over the map. We have data based on screening from 6 to 25%, with an increase in 50% when mothers also experience postpartum depression. I noticed this morning that UpToDate actually has a whole review of postpartum depression. Their definition is based on formal assessment of depression using not the Edinburgh screen, but a formal depression assessment, and have a much lower incidence of depression in fathers. I think the problem with that measure is that a lot of the fathers that test positive on the Edinburgh screen are probably not going to go on and be assessed with a formal assessment. So I'm not surprised that that's a much lower prevalence rate. It is important to note that the issues for postpartum depression, the risk factors for fathers with postpartum depression are really illustrate the issues of systemic racism and the lack of equity, so that non-resident fathers have much higher depression symptoms during the transition to fatherhood. But the other issues are poverty, a past history of depression, and certainly, as I mentioned, an increase when mothers are also depressed. Now, it's also important to note the positive impact of fathers when mothers are depressed. So if fathers are not depressed, they're really able to support a much more resilient family. And that's something we really need to emphasize as pediatricians, the power of engaging fathers. Now, a lot of the data suggests that fathers not only are display symptoms of depression prenatally, but postnatally, their symptoms may actually start a little later than those with mothers, more like 3 or 4 months, and continue on through the whole first year. Fathers are 1.38 times more likely to be depressed than comparably aged males who are not fathers. As I mentioned, the issues of equity, sleep deprivation, and essentially having a sick or premature infant is also a significant risk factor for postpartum depression and mood disorders. Now, the important point that we're going to get to today is what a missed opportunity it is that we screen mothers and not fathers. There is some validation data that the Edinburgh, which is widely used to screen mothers, can also be used successfully to screen fathers. Although it is a little notable that fathers may present differently than mothers across the board with symptoms, as opposed to presenting with sadness and weepiness. Fathers may present with irritability, with externalizing behavior, avoiding emotional expression, denying vulnerability, and not necessarily seeking help, so that the importance of screening and outreach becomes even more critical. But we see that depressed fathers may present with alcohol and drug-related comorbidity, compulsive and antisocial behavior, and interpersonal conflict marked with anger and defensive assertiveness. This behavior obviously can lead to marital stress and domestic violence, can undermine breastfeeding, and is certainly associated with an increased risk of marital breakup. So, as I mentioned, onset can occur later than in women, and it needs to be considered both for fathers of young infants and fathers of older infants. Now, the other really important point to emphasize here is that when screens are positive and fathers are referred for further evaluation and treatment, there's a real gap in available therapists who are skilled and knowledgeable about meeting fathers and providing treatment. So that we've had examples of referring people and therapists saying, you know, what are you talking about? I'm not aware of postpartum depression in fathers. So there is a real need to expand the training and resources for therapists that can accept referrals for fathers. And that's going to be a challenge going forward for MCPAP from others, which we should really now begin to call MCPAP for parents. Lastly, I want to emphasize the importance of identifying postpartum mood disorders in fathers because of its impact on their children. So we have a lot of data now that it has as adverse an impact on children as maternal depression. The fathers are 4 times more likely, the depressed fathers are 4 times more likely to physically punish their infants than non-depressed fathers, less likely to read to them, more likely to spank them. Fathers' ratings of 16 domains of their lives rank the emotional experience of parenting, along with work-life conflict, as the most negative and tiring activities. So that 68% of fathers have described symptoms of depression by the time their children reach 5 years of age. So I think we really want to begin to emphasize the importance of identifying, referring, and treating fathers, both for the sake of their benefit and for the sake of their children's growth and development, and preventing the kind of associated psychopathology in children that we see in untreated paternal depression. So with that introduction, let me turn it over to my colleague. I think Dr. Friedman is going to present next and talk about his notions about a family visit at 4 months where both mothers and fathers are screened. Mark, you're on mute. Mark, there you go.
Thanks. I got you. Okay, so I have put together a whole bunch of bullet points, and some of them may be a repeat of what Mike said, but as a grandfather, father, and pediatrician, I have witnessed the emergence of a more actively engaged father over the decades of work with families. Unlike when I began my practice, today we acknowledge the changing role of fathers and the vital contributions they make to the development of their children. We also realize how important and supportive fathers can be to their parent partners. Each caregiver plays an important and varied role in nurturing their children, providing them a pathway to good health and opportunity. Fathers' roles are changing. There are more than 2 million stay-at-home dads now responsible for the care of their children. I would also say that that number is going to increase. There was an article in the Globe that of the freshman class in college, 40% now are men, and 60% are women. So there are going to be more dads in the role of the primary caregiver. The issue of postpartum depression and its effect on mom. It is a problem that has great variance. The percentages, when you look at the articles, are all over the place from 2 to 82%. The rate for moms is usually twice that for dads, while the exact frequency is not consequential. It does exist, and it has a definite impact on infant and family. Because of its lasting impact, attempts to screen for and treat postpartum depression are important. Factors that play a role in postpartum depression can include comorbid conditions such as anxiety, post-traumatic stress disorder, substance use, low socioeconomic and educational achievement, single parenting, and the number of previous pregnancies. Studies have shown that postpartum depression increases the level of suicidal ideation. Moms with postpartum depression have lower scales on the quality of life issues. Moms are more likely to smoke, affecting herself and the baby. And moms with postpartum depression have lower social support. For dads, the percentage of dads getting depressed within the first 5 years of a child's life also varies, and the numbers are all over the place from 1.2 to 68%. If a dad has a depressed partner, he is twice as likely to be depressed himself. Dads with depressed partners had significantly more stress at work and greater economic pressure. Dads received less support from in-laws, relatives, and friends. Dads who are depressed are more likely to stay at work longer, use alcohol, and/or become violent or abusive. Dads who experience depression or whose partner is depressed is less likely to be involved with the child, the mom, and both, and more likely to leave the home, in which case all people lose. The consequences for children: more sleep disturbances, poor mother-infant bonding, poorer language skills, more likely to be spanked, less likely to be read to. And then the long-term consequences, which have been written up and recently in the journal Pediatrics: behavioral problems at age 2 and at preschool and/or daycare, which can lead to a greater chance of being expelled from these programs, setting the trend for subsequent schooling. Antisocial behavioral problems, more likely to have oppositional defiance, more likely to have peer problems. Parents are more likely to separate, causing the child to miss special skills that each parent brings to parenting. The lack of either parent can impact the financial security of the family, which leads to issues with housing and nutritional insecurity. And then the last issue, for those who believe in it, is adverse childhood experiences. These can lead to emotional and physical health issues. There is evidence that living in this type of environment could cause genetic change, which can impact future generations. Detection of postpartum depression. There is the Edinburgh Postpartum Depression Screen, which has been validated both for men and women. And the scoring varies as to how wide they want the determination of depression to be, but the varying scores are between 10 and 13. The EPDS screening is embedded in also the SWIC. The EPDS has been used to score and look for dads who are depressed. There is a modified Edinburgh screening called the Edinburgh-Gotland screening tool. And they've taken a few questions from the Edinburgh and a few from the Gotland, which was more specific for men's behaviors, and they merged them. That one has also been screened and validated, though it is rarely used, even though it's a good screening tool. So the question is, where should the screening occur? Mom should be screened during the prenatal visits and then once at the 6-week postpartum visit by her OBGYN, though many women don't go to that visit. And then according to the American Academy of Pediatrics, mom should be screened at the well child visits 1 month, 2 month, 4 month, and 6 month. Medicaid does have a code for reimbursing the screener. There are no specific recommendations for dads. According to the U.S. Preventative Task Force, all adults over 18 should be screened yearly for depression, regardless of parenthood. Yet health insurers recommend health maintenance for men only every 2 to 3 years for screening. If you look at men under 40, I would say most don't go to an internist. So the only physician that the fathers are likely to see regularly is the pediatrician. Therefore, it is incumbent on the pediatrician, in order to secure a nurturing home, to screen dads. So the question is, why aren't dads being screened? Well, here are a couple of reasons. Data is limited on the number of moms being screened and non-existent for dads. Reasons given by pediatricians for not screening include no time during visits, inadequate training, mom and dads are not the patients, liability issues, follow-up care may not be possible, screening would open a Pandora's box, no information for referrals, no reimbursement for screening. As I suggested to Mike, if you go to the Community Catalyst website and look for blogs, this woman, Eva Stoll, and I put together what we call the 4-month family visit. What that is it's a visit twice as long as a regular well child visit. So it would be a half hour. Both parents would be screened for postpartum depression. And this would be an opportunity for the dad to become seen at a well child visit. And hopefully, if there are issues, they could be dealt with by referral. Additional issues interfering with screening: culturally sensitive interventions are needed, transportation for interventions, child care, intervention needs to be covered by medical insurance, referrals to providers must be available, and there must be coding. So how can we improve screening and intervention? Better reimbursement, best practices shared by providers, better follow-up by the state insurance to see that there's compliance, working with the AAP to improve education regarding screening, and the issue that politicians look for is return on investment. Well, you won't see the return on investment initially in the first couple of years. It's going to be 10 to 15 years down the road when more of these young children graduate from high school, go off to college, and get better jobs. One last point, well, two last points. There's an article by a medical group in Dartmouth Medical School laying out how people in a practice can motivate their partners and associates to do a better job in regards to screening. And the last thing I would suggest is that there's a pediatric in research in office setting, which looks at evaluating lots of things like how to evaluate a 6-week-old that has fever. If those people could be engaged to, one, validate the screens again, including the Edinburgh Gotland screening, and then work on best practices and study that so that that information could be reinforced for pediatricians in practice, I think that would be very helpful also. That's all I have at this point.
Okay, well, which one of the members of the panel would like to speak next?
Yes, I will go. Thank you for the
Daniel, thank you so much.
Yes, thank you for the invitation. And definitely want to just highlight some things just to sum up what it is that we are seeing in the research as it relates to what's going on with fathers. But specifically, I want to pinpoint these 5 things that were called out in the study conducted by Donovan, right? That fathers are experiencing, number one, this ambivalence in early stages of pregnancy. And when we get to the latter part of the pregnancy, that ambivalence continues, right? Relationship with baby is not real, difficult time trying to connect. Also question around how should a father be, right? And coping with the changes of lifestyle and disequilibrium in relationships with their partner. Now, one thing that we have to include in this change is as the father is experiencing this transition into fatherhood and even dealing with it postpartum is the effects of racism and systemic oppression, right? We also cannot leave out fathers who are behind bars, who are also trying to remain engaged in their kids' lives, who may not be able to show up to the pregnancy given that they are incarcerated. And these are the issues that we are experiencing at Fathers Uplift, right? Fathers Uplift is the country's first mental health and substance use treatment facility that really focuses on providing a comprehensive array of care for fathers at every stage of their journey as fathers, from the time that they become fathers to the moments that they're disengaged from their children due to, in the state of Massachusetts, a high percentage of child welfare cases, fathers with histories of incarceration and fathers that have high child support arrearages and payments find it difficult to re-engage. They're also looked down upon. So provide them advocacy with re-engaging, right? We also at Fathers Uplift train future practitioners, social workers, psychologists with how to engage fathers at every stage of their journey in the fatherhood realm. Currently, we're working with schools such as Boston University, Boston College. We have interns from Vanderbilt and throughout the country who come to our site to learn, how do I work with fathers? How do I engage them in parenting, but also how do I specifically engage them in self-parenting? Because what the research tells us about what happens to fathers as they are transitioning into fatherhood and after, it tells us that we have to really teach them how to care for themselves as they are in the process of trying to be there for other people. Typically in interventions as it relates to fatherhood, and when you look at many of the curriculums out there in the world today, there's a huge focus on teaching fathers how to be parents, right? How to parent another person, but also during their whole pregnancy phase, teaching fathers how to be present for the mother. But there isn't really much support with teaching fathers how to be present for themselves as they are being taught how to be present for everyone else, right? Also, there one gap, right? And I'm really happy about this focus on how to screen the experiences that fathers are dealing with as they are transitioning into fatherhood, right? A huge issue that we see when we work with majority Black fathers at our agency is high percentage of pre-diabetes for men that are entering fatherhood that goes undetected, right? We also have a high percentage of anxiety and depression among these men that are becoming fathers that also goes undetected because it's not screened, right? And when they go into some of these places with the mother or to see what's going on with themselves, it's kind of hard to find practitioners, not kind of hard, but extremely hard to find practitioners that can engage them in the experiences that they're encountering as they're becoming fathers. So when we think about the curriculums that are being given to future students and future practitioners, and I can't really speak about the discipline of medicine, but I can confidently speak about the discipline of psychology and social work, because we have those students entering our agency, receiving training and practicum and participating in our comprehensive course that teaches them about theoretical frameworks to help them understand how to engage men, but also how to engage Black and brown men. There isn't hardly any curriculums that prepare them on how to remain present and re-engage and engage fathers along their journey to really being the fathers that they've always dreamed of being. So we had to create that resource and that opportunity to make sure that they get the instruction so they can be practitioners that we need, not just for mothers and children, but also for fathers as they are trying to be the best parents that they could be, whether they are disengaged because they're incarcerated, whether they're disengaged because they stumble due to substance use related disorders, which is a huge issue in our community that we deal with as the substance use portion of our agency. Alcohol, cannabis use, right? Opiates. We also see the research that has revealed since the pandemic that there's been a high percentage of deaths due to opioids in the Black community, right? So we have to really think about how do we make sure that future practitioners show up and be present, right? And we know what the research says, but there's also a gap in research specifically dealing with Black and brown men. What are their experiences? And also dealing with the women that are in their lives. We recently did a study with majority Black and African-American mothers who had a lot to say about what they felt the experiences of fathers were who were transitioned into fatherhood. And we see that there was overlap with the research. These fathers felt like they were with the third wheel. They were experiencing physiological changes, weight gain, depression, hygiene changes, right? But also one thing that study revealed to us, that there was this automatically assumption, especially with Black and African-American mothers, that they were raising their children by themselves. And typically the practitioners did not ask them questions about the father because it was automatically assumed that they were a single Black mother. So we're talking about doctors that were in this study. We're talking about social workers that were in the study. And although the fathers some were engaged and some were disengaged, there was already that lumping of those individuals into this category of raising children by themselves with an absent father, and the practitioner did not ask them a question about where the father was. They automatically assumed that they were the absent Black woman, reinforcing that myth that there's a high percentage of single Black mothers in our nation, right? Partially true, but it isn't the full story, right? So when we think about these various assumptions and our own experiences with fathers and what they are experiencing, we have to be cognizant of what we're doing and how we're projecting onto those that we're serving. And also we understood that sometimes it can be hard to ask about the father's whereabouts. So how can we make sure that practitioners have the skills and the tools they need to be able to do that? And we believe that more training, more curriculums, more support for institutions and doctors to really engage fathers, whether it's the OBGYN office, whether it is the pediatrician, whether it is your local social worker who needs to be informed about resources in the community. They need time, resources, and money to be able to engage fathers. And also when you look at reimbursement sheets, there isn't many that really focus on engaging fathers at every phase. Well, there isn't hardly reimbursements that really focus on specific engagement efforts for fathers that are dealing with substance use, specific engagement efforts for fathers that are experiencing the effects of becoming new dads, right? That's something that we have to explore, that we would ask insurers and policymakers to really explore. How do we create reimbursements for practitioners that are working with fathers at every stage of their engagement to increase father engagement, right? There is a high percentage of father engagement. How can we make sure that we don't lose fathers who go through these physiological, emotional, and mental effects as they're transitioning into fatherhood? And one of the solutions that we created was something that we call fatherapy. Like I told you before, we don't really focus on supporting fathers with parenting children and being there for other people. Our main focus is how do we teach fathers to parent themselves so they can be better parents to their children. And we did that through an intervention that we call follow repeat, which consists of our managing emotions. You know, the assumption often that we see when we go and talk to many people in the community and throughout the country is that men only experience one emotion, that's anger. No, we experience many emotions: sadness, happiness. So managing emotions really looks at the continuum of emotions and really help fathers put into perspective to be able to not only speak English, but speak emotions. How do you communicate what's going on with you? And pre-father care, which is prenatal care for fathers, really focuses on providing a supportive gateway for fathers as they're transitioning into fatherhood. And how do we give them guidance to address many of the issues that are reflected in the literature, right? When we think about what our fathers are experiencing from 5th weeks of the pregnancy, from the time that they find out that they're being fathers to the 35th and 37th week, why do those things have to go untreated until after the child is born? That shouldn't be the case. We should come together as a collective community and make sure that we have a continuum of supports, services, and make sure practitioners are reimbursed for those engagements. So no father is left behind, just like no child is left behind, right?
Hey, Dr. Daniels.
Yes.
Yeah, sorry to cut in, but there's a comment from one of the audience members, Ilana Schmidt. I think you've already answered this question in a significant way, but there may be more to say about this. She brings up that outside of newborn visits, that she doesn't see fathers very often at well visits, and she has really a hard time getting them in, and she presumably, is very welcoming. And so in addition to the program that you mentioned, I wonder if there's any practical tips that you can give to pediatric primary care providers to try to help engage them, to get them into the room, and as a first step.
Absolutely. So, we see this as, one prevalent issue at Fathers Uplift, but we see one prevalent solution is to continue engaging, right? Sending home materials, sending home letters of appreciation. Let the father know, hey, maybe we didn't meet, maybe we didn't see you today, but just know that we're here to support. A phone call, a nice voice message, right? And I know that time is limited, but these things really open up the gateway for fathers to feel appreciated. Because when we look at the systemic assumption of what, the medical institution focuses on, right? Many men in this country, I'm not speaking for all men, but for many men in our research and what we see when we go throughout the country, we're talking to different practitioners and providers, there's automatically this image that is linked to medical practitioners in the medical institution, that they're for women and children, right? And men are not a part of that. And also, if we look at Black people, right, there's a lot of fear that's connected to that institution. When we look at the oppression, you think about things such as the Tuskegee experiment. Those things don't go away because history, because time has went away, right? History is still imprinted in many communities of color. They're still talking about those things, right? The fear to really engage the medical institution in new and innovative ways. So there's a lot of energy, even for us as clinicians of color with our clinic, there's a lot of energy with letting the father know that, hey, we're here for you when you need it. And you may not be at the well visit, because also we see what happened to many of our fathers that may not go to the well visit or or who can't, really just participate on an ongoing basis. A lot of them are working, their behinds off, right? Trying to make sure that they can make ends meet to make sure that the mother of the child can come home to something nice. There's also dads who may be incarcerated and don't even know how they can stay engaged, even behind bars, right? We also have a lot of relational issues. Maternal gatekeeping is a real big issue that we see. So I say practical advice, don't stop trying, right? If you can make a letter template and make it, personalize it for that father, send it home, right? Call, leave nice voice messages. We tell our practitioners all the time, there's nothing wrong with a friendly voice message to let the father know, hey, we saw such and such. We just want to make sure that you have a place too. We would love just to catch up if we have some time, and keep calling, even though the father may not respond. And what we find is that they eventually respond. So, when they don't show up initially to a meeting, we know that we got to keep going. And we're probably getting them the second or third month down the line after the first day, but there's continuous follow-up, right? It doesn't stop after one call. And I think what we find a lot of people stop after the first 2 or 3 weeks when the father isn't responding. And we believe that that's premature. We believe that we have to keep doing it because they listen to those voice messages. They read those text messages. If you have a text system, right? They read the letters, right? I mean, that's a very, I would say, small thing that we find to be very great when it comes to our engagement efforts. Like I said before, we've been able to engage over 12,000 fathers last year through our in-person interventions, but also through our indirect interventions, right? Because we teach people about how to be customer friendly when it comes to fathers and help them let down that guard. Because when you look at the system, it's easy for us not to feel included in it. So they're going to take a lot of work for you to make us feel included, not just medical practitioners, but also social workers, any mental professional.
Excellent.
And I'm
Good
sorry.
point. No, those are very, very useful practical points, Dr. Daniels. Thank you so much.
And I think I'm talking too much, but hey, I got plenty of research and information. If you want to email me, follow up, I can definitely send over some of the literature that we found the bibliography. If you want to do some reading up on what fathers are experiencing during the pregnancy. I know Dr. Yami has a lot of information about postpartum as well as Dr. Friedman. But I can definitely help with the engagement side of things and how to keep dads involved when it seems as if they don't want to be involved. So thank you for having me. Glad to be here.
Great, thank you. And as always, again, I'm Daniel Rodriguez. I am just excited to be here, and it's always such a privilege to hear the other speakers. And being on the heels of Dr. Daniels, I could hear him speak for days and days. So it's a privilege to be able to speak after Dr. Daniels. I just want to begin just by saying, again, it's an honor to be able to speak about this incredibly important topic, but also recognizing that, this is during a time where women's reproductive rights are, very much so in a vulnerable position. And speaking about paternal and perinatal mood disorders in a time and space where, again, women's health is in a very vulnerable position, recognizing that as a cisgender male, as a passing person of color, speaking about the need for men to be elevated again can be at times a little off-putting. Just recognizing that for a moment, letting that sink in, I feel like I needed to say that. But coming into this conversation kind of with two lenses, one as a clinician and also as a father who has experienced and continues to experience a perinatal mood disorder, I do believe it is an incredibly important topic, and I am honored to be able to speak about those experiences today. So recognizing that I don't want to take all your day today, I thought that I'd like to begin my portion of the conversation by talking more about the personal and then about the professional, and just sharing about kind of my experiences with my perinatal mood disorder, how that impacted kind of my experience as a father, my relationship with my children and my partnership, and how that kind of shifted into my professional work, as well as just kind of, where I am today. So just I'll just begin with a little bit of a backstory. Professionally, as shared at the beginning, my current role is I am the director of a substance use disorder programming at a federally qualified health center on Cape Cod. My work, we work with individuals who are unhoused or unstably housed. And as part of that program, we have a specialty program serving pregnant and parenting women with histories of substance use disorder. In addition to that, before I came to this health center, I worked on a local labor and delivery unit as the clinical social worker, and very early on in that incredibly intimate space for women and families, obviously delivering their children, recognized that mental health for women was not being addressed at all, and even less was mental health for fathers and partners being addressed, and recognize that in that critical moment of when a mother was obviously delivering and super vulnerable with regard to kind of the emotional cascade of everything that she was feeling with her delivery, and kind of preparing for her postpartum experience, and a father trying to stand there, sit there, and kind of take in everything that just happened and planning for next stages. building an opportunity to kind of process and figure out what, the risks were for them and how to kind of prepare, wasn't existent. So that set the stage for me, from a professional standpoint. Fast forward again, kind of going into the personal to myself. I have two children, a 6-year-old and a 3-year-old. With my first child, Isabella, did not experience any particular symptoms of perinatal mood disorder. And then a little over 3 years ago with my son, Nathan, he was born right around Christmas time, or excuse me, New Year's Eve. I take that back. And after he was born, things definitely changed for me. And working in the field, doing this as a mental health clinician and specializing in perinatal mental health, holding a certificate in perinatal mental health, I was blindsided with experiencing a perinatal mood disorder. It took me over a year to actually finally put my finger on the pulse and come to the conclusion and actually give myself permission to recognize that I was truly struggling with a perinatal mood disorder. And what that looked like for me was increased agitation, a lot of anxiety, depression, a lot of distance, disconnect from my son. I can vividly recall, and then COVID struck, just to kind of throw that monkey wrench into all of it. And I can vividly recall sitting on my couch after coming back from work during COVID, still being in the office, holding my son in my arms, being on the phone with my provider, looking down at him and saying, talking to my provider and saying, something is wrong. I do not feel connected to my son. I need to figure something out in making the decision to, seek medications for my mental health. And it's taken me about 2 years to kind of get to a point now where I feel like I've been able to rebound and to build a relationship with him where it feels real. And I feel like I've been able to make up for lost time. And that's the reality of actually addressing a perinatal mood disorder in a father, let alone not addressing a perinatal mood disorder in a father. So let's put that into perspective for the folks that are on this call. And I have to say, I'm blessed today to be taking this call, sitting on a Maine coastline with the breeze behind me. And that's because I have made the decision to not put family time, beside, to the side, to prioritize work, because making family memories is important to the rebuilding process, given my mental health. So that is a part of the rebuilding process for me, is to be able to do that. So again, focusing as providers on having these conversations with our patients is incredibly important, and making space for our fathers is incredibly pivotal when we look at how we are assessing our family systems. Now let's switch over to the professional lens. So looking at our landscape on Cape Cod, we recognize that, again, assessing perinatal mood disorders across the spectrum, both for moms, fathers, partners, it just wasn't happening. So from a labor and delivery perspective, we started to institute some screening tools, really based off of Cheryl Taitano Beck's work out of Connecticut on risk scale assessment for risks for perinatal mood disorders. We looked at that primarily for moms, and then started to kind of use some of those risks to have those conversations with dads. When we translated some of our findings to working with pregnant and parenting women with histories of substance use disorder, what we saw is that we had recovery coaches that were working with these moms, and those recovery coaches were indicating that moms were doing really well, that they were having positive outcomes, but historically, when working with systems like Department of Children and Families, they were having negative outcomes with DCF due to intimate partner relationships, specifically dads weren't doing so well. When trying to figure out what the need sets were, lo and behold, fathers were not as stable in their recovery. And typically the underlying theme was either continued substance use or disconnect from the child, or mental health struggles seemed to be a really kind of strong thread along kind of the line of the story. So what we ended up doing here through First Steps Together, as well as the Coalition for Children on CAPE, was to create a Dads in Recovery support group, which meets weekly to be able to serve fathers in recovery who want to come to be in a space with other dads in recovery to talk about recovery, mental health, perinatal mood disorders, just really a safe space for fathers to be able to be themselves, be vulnerable with other dads, to share anything that they'd like to share, that in an area that they do not need to feel judged. Because one of the biggest things that obviously we need to cut through with regard to our culture here in the United States is that the machismo culture of men need to be these strong, empowered individuals, and we can't show any particular emotion. And as other participants on this call have shared, that's not the reality anymore. Active parenthood is the ideal now. It's no longer lopsided parenting. It's not 50-50 parenting. It's 100% parenting. What we're also doing is trying to integrate more peer-led father support groups for perinatal mood disorders. So we're looking to kind of create a couple more of those spaces moving forward here on CAPE. But again, creating spaces for fathers to feel comfortable sharing their emotions, sharing their feelings, being able to cut through a lot of the socially constructed frameworks that we've had to live in as fathers, is something that we're really looking to do, and also really trying to parse out culturally kind of set tones that we've been taught as individuals, to be able to create those spaces as well. So then that way we can also tease out some of those things that we've learned culturally as in our upbringings, that we can also shed as part of this work as well. So again, just really grateful to be able to come in with both of those lenses, and have an opportunity to answer any questions, both from a personal lens as a father who has experienced and continues to experience, again, a paternal perinatal mood disorder, and a clinician who continues to work with and for fathers who experience paternal mood disorder. So thank you.
Well, thank you, Dan, and we really appreciate all the perspectives that you brought to the discussion, as well, and especially, just having people speak of their lived experiences is so powerful, I think, for all of us. So what we do have about 7 minutes left.
Barry,
Go ahead.
Barry, I'm sorry. Do you mind if I just add one more thing? I was thinking, I didn't mean.
Go right ahead. Yeah.
So I was thinking, it was Miss Alyssa who asked a question about how to engage fathers in pediatric visits. Was that right?
Yes. Yes.
All right. So my ears perked up during that question to Dr. Daniels, because I am a father who has attended wellness visits, and actually, as a professional provider who sat in some of these visits, there's been moments where I've been like, what the hell happened? So one thing that I've noticed is a lot of times, even being in a space with my wife, I feel like an outsider. A lot of times I am in the room with my child and my wife, and when the pediatrician comes into the room, all questions are geared and truly, literally asked to my wife. And if I answer a question or if I ask a question, the answer is immediately answered to my partner. So I think that a part of bedside manner when it comes to providers is figuring out how to also, when we talk about creating space, I'm a good old social worker. How do we hold space in the room to, create a warm environment for partners to be able to feel included in that room as well?
That's really, really, I think, such an important point. And I do think that that point, as well as what Dr. Daniels was saying about just, the strategies of how people can intentionally really send a message that they believe that father's important, that their voices are important, that they really belong in the room. There are all kinds of practical ways that we can do that that could contribute to changes. But some of this is really interpersonal processes. Some of it could be office processes, front desk processes. I'm not always sure that we always collect the information about how to contact dads. I think that sometimes they don't even have the address or the phone number to call and reach out to them as well. But we have a few more minutes. We just have about 4 minutes, and we don't have any questions right now in the question box. But I'm wondering if other panelists, have thoughts about this or other kinds of practical tips, that can help to kind of move the needle and make a difference. In addition to all this consciousness raising and advocacy that needs to be done, I think that I'm curious about other practical advice that could be implemented very easily to kind of address this.
Hey, Barry, I have one thing too, because I think one of the major complaints that we hear about fathers men who are transitioning into fatherhood is that they're automatically turned off by front desk staff. So it'd be good for each practice if you have a relationship with your front desk person, typically before that man gets to you, even if you were to establish a relationship outside of the actual visit, anything could happen when he comes to the office and meets with the front desk person. We believe that that's one of the most important people in any office setting, right? If a father is showing up to the office and is automatically taken aback by how he's treated by that front desk person, it can really throw off the visit, and it can reinforce any stereotypes or assumptions that he may have about you as a practitioner. So any training as it relates to fatherhood engagement, we believe that front desk personnel needs to be in those trainings, right? From the administrative assistant to the billing coordinator, right? We need to have all those individuals on the same accord when it comes to keeping fathers engaged, because they can either create the culture or destroy the culture. And we find that being the case the majority of the time. So I think really establishing relationships with that front desk administrative staff, and even if they get a heads up that a father is coming to the office with the person, right? Or that you've been reaching out to this father, if they can support with any type of housekeeping, it'll be very great. Because I would say again, and I can't push this enough, front desk personnel from any capacity, billing capacity, administrative capacity, one of the most important positions when it comes to engaging fathers. And it's important that we have them on the same accord. So that's what we're pushing now, because our front desk staff at our agency creates the culture. They're lively, they're smiling, right? And we don't want anything outside of that. So just a heads up.
Fantastic points. So we are at the end of our time. We're just a moment away. So I just want to take this opportunity to thank all of our speakers for really compelling presentations and all the good information that they've shared with us today. I want to thank the audience for coming. I do want to just remind people that they can ask other questions, and we can forward them to our speakers. If you send an email to mcpap@beaconhealthoptions.com. Please don't forget about the survey, and just tell your friends that the recording is available on the website, so they don't have to miss it if they weren't able to be here. And we will look forward to seeing everyone in September. So thanks again.